Today we have a special guest for our seminar. So it's my great pleasure to introduce Dr. Daniel Mueller and PhD candidate Victoria Marsh in his lab as our virtual speakers. Since there are two speakers for today's seminar, I will introduce them as briefly and quickly as possible in order to give them enough time for their talk. Dr. Mueller received an MD PhD at the University of Bonn in Germany, and he completed his postdoctoral research at the Institute of Human Genetics in the University of and Center for Addiction and Mental Health in Toronto as well. After his postdoctoral research, he became an assistant professor at the Department of Psychiatry in the University of Toronto in 2008, then an associate professor in 2011, and now he is a full professor at the department in the university since 2017. At the same time, he is a certified psychiatrist in Germany, and he has a psychiatry medical license from Canada. Also, he has a head of pharmacogenetics research clinic at the Center for Addiction and Mental Health since 2008. Dr. Mueller published around 100 research articles with the first or last authorships, and the overall number of publications is about 230. He's currently receiving 8 ongoing funds from diverse sources in Canada and the US, including Canadian Institute of Health Research operating grant for predicting antidepressant remission in late life depression using polygenic risk scoring and machine learning models. So Dr. Mueller is an expert in pharmacogenetics and psychiatric genetics in terms of clinical practice to predict any diverse drug events or inefficacy from people using a variety of methods like GWAS and even machine learning. His works broaden our knowledge on association and interaction between genetic characteristics and drugs. So it's essential for better clinical treatment outcomes as well as personalized medicine. The other guest speaker is Victoria Marsh, who is currently a PhD candidate supervised under Dr. Mueller and Dr. Sidney Kennedy in the University of Toronto. She earned a bachelor's degree on neuroscience and psychology major in the University of Toronto in 2014 and a master's degree in the same university in 2016. She has already published around 15 research articles since 2015, and also she has been sharing her expertise and brilliant insight on pharmacogenetics and psychiatric genetics through conference talks and posters. Now she is conducting her research on the title of predicting antidepressant remission in late life depression using polygenic risk scoring and machine learning models funded by Canadian Institute for Health Research with Dr. Mueller. So welcome and thank you for your time out of a busy schedule for this talk today. And I just wanted to mention real quick, if you leave questions in chat, and then we will be able to handle them at the end of this first talk and Q&A session. So thank you and welcome.
Thank you so much for this kind introduction and for the invitation and for the superb organization despite the difficult weather conditions. I understand that has hit Memphis and the southern US. So it's a pleasure to talk, to speak, and to update maybe some of you about pharmacogenetics and psychiatry specifically. And we like to be translation as much as possible. So you're going to hear first a little bit about what we're currently doing, which research has made it from bench to bedside, if you wish, or from sequence to script, as we might say, or from from neuron to neighborhood. And then the second part by Victoria will be our experimental, basically our experimental work, current experimental work, and work that we will follow up with using genomics, polygenic risk scores, and so on. So if you're interested in some practice, this is now the time to be here, half an hour or so, and then Victoria will take over. Thank you so much again. And where are we? I just want to briefly introduce the concept of mental illness, just in case you wonder what are we doing there and who are we treating. So a mental illness is defined as, typically it's important to look at the context. It's important to look at what do people really are stressed about, what their thoughts are, what their feelings are, and how they behave, right? And you can imagine that depending on the condition, you might have more to deal with a problem in this area or sometimes more in another area. But that's basically the fundamental principle is, you look at those things in each of your clients or patients that come to see you. And common psychiatric conditions, there's a lot of them listed here on the left, so there's a lot really that is being addressed by psychiatrists. However, often there is this notion about spectrum, so I mean, for example, if you look at mood disorders, anxiety or depression, we can certainly understand that everyone might have bad moments, bad days, even maybe, but when does it really matter? That is an important question that psychiatrist has to address. When is really treatment, or when are really treatment recommendations important or not? And on the left we have, the classic psychiatric conditions, and on the right we also have psychiatric conditions, but those are the personality disorders, which are very much require very much more psychological psychotherapy interventions. So I'm not going to talk about those today. I'm going to talk mostly about those ones here, about the mood disorders and psychotic disorders, simply because those are the ones which receive antidepressant and antipsychotics respectively, and which are very commonly prescribed medications, and where we believe that with pharmacogenetics we can optimize treatment. So the context and functionality are important. So basically, if you ask yourself, when is someone, when does someone needs to see a psychiatrist, you can basically use a simple formula. If someone has a full-time employment and is able to manage that, able to show up in the morning, able to deal with the stresses, able to talk to people, able to manage people, and be productive, and I don't know, then, sorry, I have to kill this. Then that's definitely then a good sign that someone probably is not so ill. But also managing a stable relationship with a partner, it's a very challenging thing to live with. You have to adapt to someone else, you have to understand someone, you have to support someone, you have to take care of someone sometimes. So these two things, if you look at those, and if someone can manage at least one of them very well, it is often unlikely that there is a severe psychiatric condition. Now, it doesn't mean people are happy or something, but this is not about psychiatry. Psychiatry is not about happiness. It's really about helping people to do, to get back to their lives and to function. Then they can pursue their own happiness, right? And I'm also not saying someone who has no job and has no partner has a psychiatric condition. Don't get me wrong. People can be very happy without either of those. But the point is when they suffer from it, when they say I can't go to work anymore because my depression is so bad, or I lost my partner because my anxiety was too much for him. That's when we say, okay, here you should probably think about treatment, right? So, and are psychiatric conditions common? Maybe that's a question to the group. A bit of interaction here. I can't see all the people here, but is there anyone who thinks they're common? Maybe just say yes, or maybe just show up. Yes.
Yes.
Thank you. Yeah. In fact, they are very common, and common means also they are they have a life prevalence. They have a long prevalence in life because they start so early, right? So because most of the psychiatric conditions manifest themselves within the first 3 decades of life, and then they might be there for the rest of their life, so many decades. So they're first common because there's a huge prevalence, and unfortunately also because It has to do, often people have difficulties with managing life stressors, and so eventually, if that becomes too much, people then develop maybe certain conditions. So it is common. Here are just numbers, and those numbers are very kind of different across nations and across countries. And that does not mean that in one country there's more mental illness than in another. It just tells us basically that it depends probably on how you look at it, and who has access to treatment, and who is recognized or diagnosed. And we see globally a huge underserving of psychiatric conditions. If I tell you that Switzerland has most psychiatrists, you might think, oh, then probably people in Switzerland might have more problems than others. No, it's because it's the richest country in the world, one of the richest countries in the world, and they can afford so many psychiatrists, basically. So it's a luxury, actually. It's still a luxury in many countries to have psychiatric services, and even in our Western world, it's not. I see a huge amount of people underserved, and despite that, it is so common. And that has to do with a lot of things. I'm not going to go into detail here, but just to let you know, it is a problem. It is common, and there is a lot of underserving. So we need to do better also in research, because we need to handle the vast amount of people who might eventually seek treatment. And if I talk about treatment, medication is only one of the three main pillars. Psychotherapy is extremely important as well. Social assistance is extremely important as well. I'm not saying psychiatry is only about medication, but this is what we talk about today, because this is the biological intervention that we do, and this is where genetics play a role. And if we look into medications, again, we have a huge laundry list here of possible medication that can be prescribed for different conditions, and and with different receptor neurotransmitter profiles and so on. But I want to focus on those which are circled in red here, because those are the ones which are commonly prescribed, and those are the ones where genetics really matter or can make a difference. And these are the antidepressants, the antipsychotics, and among the mood stabilizers, carbamazepine and oxcarbazepine. Okay, and now we have a problem. So we have all these nice medications. We now recognize someone is needing treatment. Someone is also willing to have treatment, and now we have a problem. And the problem is the great variability. This is a quote from Sir William Osler, from 1890, and you can imagine you'll be surprised basically that this situation is still the same pretty much, because now we have all these medications and we don't know who's going to respond to which one and to which dose. And so it's often frustrating to take weeks and months to find the right medications for the right patient. And this variability is very common for these psychiatric medications. In fact, for antidepressant and psychotics, I mean, an anesthetic, thanks God, when they have to do surgery on us, it's just a matter of a dose maybe, but we will all eventually become sedated and, get our muscle relaxed or something. It might matter on the genetics as well. I'm not saying this, but most of the time, 99% will have an easy going with their anesthesiologist, right? Psychiatry will probably are at, 50% chance at the first try that, it goes well. And that's very, very, very much slower rates, right? So the variability is determined by many factors. We know that age matters, gender matters, ancestry will matter. These things are all in our mind when we prescribe. So there is some personalized medications or treatment, if you wish, because we keep these things in mind. Typically, in psychiatry, we will also look at the clinical subtype. Someone is depressed, so some have sleep problems, some have not. So we might give, medication which is more sedating, or we prescribe an extra sleep medication and so on. We will also be very mindful about drug-drug interactions, because these can cause a lot of problems. And I talk about phenoconversion, right? Phenoconversion. I'm going to give you an example in a moment. And however, what we're trying to do here is to look at drug-gene interactions, right? Drug-gene interactions, basically, that's something new here on the list that we're passionate about, and we like to understand those. Pharmacologically speaking, we do have two compartments in our system. One is what is the body doing to the drug, which means metabolizing, and that's called pharmacokinetics. And here we have those so-called phase 1 enzymes very prominently be involved. CYP2D6, CYP2C19 particularly, are very prominent genes. By the way, ALDH2 is also a phase 1 enzyme. right? So ALDH2, the one which metabolizes acetaldehyde from alcohol, which makes people sometimes not tolerate alcohol very well. It's also phase 1 enzyme. And then, however, we have the other compartment, the pharmacodynamic one, which means what is a drug doing to the body? In our case, it's most likely the brain that our medication should work in order to treat things like mood problems and so on. But there will be some peripheral mechanism maybe involved, but basically that's the pharmacodynamic component. And while we have a very good understanding of how medications are metabolized, we have very little understanding how the drugs really really work and why they work in the brain. So that's the pharmacodynamic is still a puzzle, still a question mark, so to speak. Whereas for the phase 1 enzymes, for the metabolism, we know very well what is happening. Then, just to mention them, we have also a few other things here listed below, which will interfere somewhat with these two compartments, and I think one of them is hypersensitivity to medications. And here we talk about the HLA and HLB genes, and this is where in psychiatry we have this HLA and HLB genes that we can test for identifying hypersensitivity against carbamazepine and oxcarbazepine. So this is basically the play at this moment, which I will mention more in detail now. So if you look at, sorry, this is a slide that made it from my German presentation last week, excuse me. But anyway, it means relationship of frequency of individual enzymes in the metabolism of psychiatric medication or psychopharmacology. And it's not about how frequent these enzymes are in our body, in our liver typically. It means how important they are for psychiatric medications. And you can see three major players, if you wish: CYP2D6, CYP3A4, CYP2C19, right? They do about 75% of the drug metabolism. Now, CYP2D6 and CYP2C19 are genetically extremely variable, and therefore genetic testing can be very interesting here. CYP3A4 is less genetically variable and is much more abundant. It is so prevalent that it is hard to really, that genetic variation might have a major role. But for CYP2D6, we have two problems. We have we have a low capacity. The system is quickly overloaded, and we have a high affinity. Means medications which are primarily metabolized by CYP2D6 have to go through CYP2D6, otherwise they do not get metabolized, right? So this is the notion about CYP2D6 here. And the other ones, 1A2, 2B6, just to keep them in mind maybe, but for now they don't play a major role in day-to-day genetic testing. And here is an example of a medication. Sorry, again, German slide, my apologies. I should have done a better job, I guess. But it's easy to understand. You have different people here. Let's say you have four different people for CYP2D6 metabolizer status, and you have the poor metabolizer, the intermediate, the normal, and the ultra rapid. And I think you've heard about them before. For example, from Andrea Gaddick's talk, I think a couple of weeks ago or so. But now, if what you can see here is that people who take the same dose of a medication can have very different serum levels of paroxetine, an antidepressant, which is highly metabolized by 2D6, depending on their CYP2D6 enzyme activity, which is genetically based. And you can imagine that the poor metabolizer here at 40 milligrams get into serious problems, into some intoxication effects, whereas the ultra rapid metabolizer doesn't feel much about the medication. Maybe the metabolites will do something, but typically, if this patient doesn't respond and someone does a serum level and they see it so low, they might accuse the patients of not taking the medications if they forget to look at the metabolites, right? So these are the issues, and this is well known since a long time. So the question is, why are we not doing it since? This is not just science from yesterday or so. Dr. Kahlo, that was mentioned earlier, talked about this in the 1990s. Back then, genotyping was maybe more complicated and expensive, but why are we not doing it? Well, and I think one reason is before I go there, why are we not doing it? Let me just present one case to highlight the importance of CYP2D6 and also the tragedy of phenoconversion. Okay, so this is a real case, happened in the 1990s. And was investigated by Dr. Prescorn from the University of Kansas, and so he saw this this widow, this woman, coming to him asking him for advice. What happened? Her husband, and they were kind of about to be, they were in a, they were about to split up the relationship. So the husband was living alone, and she was living with her son somewhere else, and he was depressed. He lost his job because of his depression. Now he was also in this relationship strain. He went to the doctor. The doctor first gave him an old antidepressant, amitriptyline, and then he heard about this new one, fluoxetine, Prozac, which just came out. So he added Prozac, hoping that two medications work better than one. Unfortunately, 6 weeks later, that man was found dead in his apartment. And they did a toxicology exam, and they found excessive levels of amitriptyline in his blood. So the constellation, being alone and divorced or about to be divorced and jobless, depressed male, all these risk factors, they concluded, the death was attributed to suicide. Now, there was one problem. First of all, the family did not believe that, couldn't believe that. There was no letter, anything like that. He apparently loved his son, so to speak, was just a few years old. And the life insurance would refuse to pay. So they contacted, she was lucky. She contacted probably Dr. Prescon, who said, okay, I have a theory here that it might not be suicide. Let me just ask you to, let me just ask the coroner to send me 3 different samples and measure the concentration of amitriptyline in 3 different body compartments. Also body compartments where it takes a long time to reach the same diffusion levels, as in the blood system. And in fact, the concentrations were all the same, even in tissues which are very poorly diffused, maybe like bone, joints, and so on. So actually, then they completely reversed this cause of death, which in fact was caused because of the inhibition of 2D6, which happened through fluoxetine. Fluoxetine is metabolized by 2D6, but it's also a very strong inhibitor. So that person, he was phenoconverted from probably a normal metabolizer of 2D6 into a poor metabolizer, and now he could no longer metabolize amitriptyline because fluoxetine was basically shutting it down. And because of that, that patient tragically died. Could have been avoided if this interaction was better known at that time. And again, for the family, it was a huge relief to know, there was no suicide. It was a tragic accident, so to speak, right? But we can learn here, you shut down one gene and you have a lethal outcome. So in my opinion, that is very much the definition of a monogenic disorder, right? You have problems with one gene, and the outcome can be devastating. So pharmacogenetics is also about having genes with huge effect sizes, like in this case, because this person could have been genetically poor metabolizer and would have had the same problem, right? And some people, I sometimes explain after this case, I say some people are born as if they were taking fluoxetine since birth. They're poor metabolizers. They're basically, they have their CYP26 system already exhausted. And so you should never add any medications which are metabolized by 26, right? So that's a learning lesson here. And again, why are we not using this? Why are we not doing this more often? I mean, why are we not testing everyone? And here's a bit of the answer. So this is a sample from Andrea Gedek. She picked a random sample of 360 so-called Caucasians, which means white people, basically, or European, with European ancestry, I guess. And the prevalence of, the frequency of poor metabolizers and rapid metabolizers, which are on both sides of the course, are relatively low, right? So there is like 2% maybe rapid metabolizers, maybe 5% or so poor metabolizers if you look at this population. And that is just a minority. So whereas you can say now, if you look from an evidence-based approach, you give all of them the same antidepressant, there is a good chance that most people will do much better than if they were taking placebo. So you would conclude, based on evidence-based medicine, everyone with depression should get this medication. But individualized medicine, personalized or precision medicine, will now tell you who is actually benefiting from the medication, as long as you do or know the genetic background, right? Because it matters. Those people do not well on medications metabolized by 26, right? So that is a reason why there is this notion we probably don't need to test, or we can't afford, or something like that. At least we couldn't afford it until now. Maybe we should now. Maybe also genotyping costs have gone down so dramatically that we should actually do it. And so it's happening more and more often, but in the past it didn't. So, and there's also an interesting notion, though, about the CYP26 activity, which is very different, again, between populations. And while the difference is not huge, but in Europe, you can clearly see that duplications are much more often happening in the southern part of Europe, towards the Middle East, whereas the slower, the slower CYP26 activity is more likely to happen in the north, with the exception of Finland, because they have a different, ancestry. There's a theory, that these immigrated from Eastern Europe or something. But I'm saying, basically, you can see already regional differences in relatively stable populations, right? I mean, where the populations are not so diverse, maybe as in other places in the world, and so you can see that obviously, you can't always just say it's rare because you have looked at one population. What might be rare in one population might be very frequent in other populations, right? And so we have, for example, and I mentioned the Plavix case earlier before we started the seminar. The Plavix, which is metabolized by 2C19, is not very common to be poor metabolizer or to find poor metabolizers in Europe, but it's very common to find them in East Asians and in the oceanic population. So just to say it's a minority is not really true for the entire world population. It really depends on which population you look at. So I think because of that, A, need more research, and B, should also not be calling this a minority effect. So, and there are papers out there. One of this is this one we did, and we found out that people who have OCD who are non-normal metabolizers for 2D6 or 2C19 were much more likely to discontinue the medication just by looking at discontinuation. And this cohort here is a cohort which is followed up by our OCD expert, Dr. Richter. She knows every patient very well, and she knew that some patients needed to go through more trials than others, and she had no clue about the genetics at that time. In retrospect, we did the genetics, and now we saw that those who did struggle more were those ones who had, in fact, who were non-normal metabolizers for 2D6 and 2C19. So that fits the picture, right? And now this was even confirmed in larger samples from a Swedish sample, which says, for 2C19, which metabolized escitalopram, in retrospect, and no physician, no patient knew about the genotypes at the time of prescription, but in retrospect, they could clearly see that those who are non-normal metabolizers for 2C19 were more likely to discontinue escitalopram. So again, it's a proof, if you wish, that those who are not normal metabolizers, either they don't respond or they may have side effects more often than the normal metabolizers did. And that's for a very commonly prescribed antidepressant medication. Escitalopram is one of the most commonly prescribed SSRI medications or antidepressant medications. And the same works for two antipsychotics, which are extremely often prescribed, risperidone and aripiprazole. Same thing, interestingly, the doctors did not know the genotypes, and the patients neither at time when they're prescribed. And it's interesting to see that the doctors were giving on average more to patients who are rapid metabolizers, so they're compensated for that to some extent. They kind of notice that patients don't show any response, so they give them more. And with poor metabolizers, they stopped earlier to titrate those patients up on risperidone, or right, and then later they looked at the genotypes, and then they saw, oh, that's interesting. Those who were rapid or poor metabolizers, in fact, was those who were more likely to discontinue, significantly more likely to discontinue. So another proof, if you wish, that, the notion of 2D6 is important. And that proves again what we already knew, so to speak, but it's coming up in every paper how much these metabolizer status are relevant in terms of not just plasma levels, but also in terms of response or non-tolerance or discontinuation of medications. So, however, some people also misunderstand pharmacogenetics, I believe, in because of something else, which I try to explain here briefly in summary. So if you have 100 patients and you treat them, and they're all different, and you treat them with two antidepressants, let's say, paroxetine, which is metabolized by 2D6, and escitalopram, which is metabolized by 2C19. What you're really doing is, you are basically seeing now two groups of, you see one group which responds well, and one group which does not respond well, let's say 50-50 or something, right? And now what you're really doing is to remove patients with a high likelihood of non-response, to remove them through pharmacogenetic testing into the cohort of a higher likelihood of response, but not saying that they will respond now because you have identified their CYP enzyme. So the CYP enzyme genotyping is about negative prediction. You take, you have a negative prediction. You can correct for it by giving them different medications, but from there on, it is just basically not guaranteed that they will respond better now. You just put them in the category of people who have a higher likelihood to respond. And I think the problem often is that people then might see the genetic test, they might take a medication which is not contraindicated, so to speak, and then they don't respond. And then they say the pharmacogenic test doesn't help. It's worthless, and companies are making money. And so I'm ranting against these companies. No, it is not about who is going to respond, which was a problem at the beginning. It was, we are trying to minimize the likelihood of non-response. And if people understand that, I think they will probably also revise their kind of attitudes against the pharmacogenic testing at this point of time. Because response had maybe to do with pharmacodynamic factors. We haven't looked at those. We are just looking at those poor responders, basically, right? And I think this is the key message here. So implementation of pharmacogenic testing is occurring particularly in larger clinic consortiums, like the Mayo Clinic is doing this mostly routinely in psychiatric patients. As far as I know, the Emerge network is doing pharmacogenic testing very often, or at least part of the program. The North Shore group is doing it. St. Jude has, clear guidelines for codeine, for example, for children, and if they're non-normal metabolizers, they will never get codeine. These are the things which are already in place in some clinics very nicely, but unfortunately not everywhere. And then there's the Monsigney system in New York. And this is us here at KMH in Toronto. And we have been doing, we have been offering this genotyping now for 10 years to patients who are referred to us to the research clinic. And here we have a result report from the early years, where we said, the red medication is the one you shouldn't take, the other one you can take, particularly the one in the green, and then you might be better off. We have included more than 11,000 patients, so we now have a nice database to look at. And interestingly, this is a publication of our first cohort. And now you can see below in the lower part of the table, you will see something surprising, because these are, this is just a subgroup of, I just want you to focus on the subgroup of European, because we know the frequencies of European so well. I showed you the picture earlier from Dr. Gedic, right? So 2% are approximately rapid metabolizers in a standard, in a random cohort, and 5% are maybe poor metabolizers, meaning not more than 10% are actually at the edge of the curves. Now, that population is referred to us are people who have not been doing well in the community. They've been treated, for example, by the family physicians or by psychiatrists in the community, and the second medication maybe didn't work well, and then they said, you know what, we'll send you to Dr. Mueller to KMH, or we send you to any doctor at KMH, and they should figure out what's happening. And now we see numbers of non-normal metabolites which are extremely higher, much higher than we would have expected, right? So in other words, you can see here, we would have expected, based on the ancestry, approximately 80% or more to be extensive metabolizers. We only saw 56%. And we would expect, 5% to be poor metabolizers. We saw 15%, 15.4. And instead of 2% rapid metabolizers, we saw 6%. So now if you add 15 to 6, you have 20% of people who are non-normal metabolizers. And those are the ones who have not responded well in the community. So now with genetics, we understood we could give them an explanation, and finally also help them and put them on the right medication, hoping that finally, they got better, and many of them did. So this was great confirmation also of what we hypothesized, right? So therefore, this is where FDA has put a labeling where they say, if you're a non-normal metabolizer for CYP26, be careful, adjust the dose, or don't even prescribe it. So it's a long laundry list here, again, of medications across psychiatric medications here, that where CYP26 matter. So I think in 2021, we really need to conclude that, being poor metabolizers is a very clinically relevant information, and it should be treated like an allergy. You want to know if someone is allergic before you give a medication. So please do the same for 2D6, find it out, put it out there, have it in the medical records, and if someone is, just treat them as they should be treated. And so the last thing I wanted to just mention, for the sake of completeness, is this very severe toxic reaction to some medications that people can experience called the Stevens-Johnson syndrome. Okay, it's a severe blistering of the skin, can be lethal, and that is a hypersensitivity, a hyperallergic reaction to certain medications. And here we know now that there is a clear association with certain HLA and HLB genotypes, and so CPIC, this consortium here has published guidelines many years ago, and now a lot of people are in the world, testing for that gene variant before prescribing carbamazepine or oxcarbazepine, which in psychiatry does not happen so often. But again, because the side effect can be so lethal, if you do a genetic panel for your patients, put this gene please on the panel just for those few people who take carbamazepine and for those few people who have these HLA and HLB gene variants. And so the CPIC consortium I just mentioned briefly, they have been going through the literature, screens the literature now for several years, and have given guidelines, recommendations for a good numbers of medications by now. So if you really want to know more about this in detail, read those guidelines. They're amazing. They're updated every few years, and there you can basically get the full understanding of what the literature, what the recommendations is based on expert knowledge. And we have then worked out a so-called minimal panel. So for those who are interested to go back into the labs and create a panel for the patients in any clinic in the world, at this point of time, these are the genes. Okay, I call them the big five. I like to call them the big five because POLG is not so, is really just more a mitochondrial disorder. So we have five left, and the big five is also a concept in psychiatry and psychology about the big five personality dimensions. So I like to call them the big five, so people remember that there are 5 genes at this point of time that are very important for psychiatry. And you can see how much they're involved in a lot of medications, right? Now, having said that, you can buy yourself test panels just for some psychiatric medications. However, why not think holistically? Anyone needs maybe also other medications in their lives, not just maybe psychiatric medications. So why not listing all the medications, all the gene drug pairs which are currently based on guidelines, based on recommendations, based on expert knowledge, important to consider. And this would be 21 genes. And now we just don't talk only about psychiatric medications, but we talk about everything else. And so ideally, the genomic medicine of the future, anyone who comes in needs a medication, get those genes at least tested for these variants, and then you will decide which pain medication is better to not take, or maybe to take, or whatever. That's genomic medicine of the future. So barriers to come to an end. Why are we not still doing it? Well, again, there's limited knowledge. Today you have learned so much, I hope, about pharmacogenetics that most people don't know about. Even patients, even physicians and patients, of course, are also not well informed if the physicians don't know, and so on. So this is really important to bring out the knowledge. This minority thing, which is almost a bit discriminatory, if you wish, or it's just for a few people, which isn't true. It's not just for those few people. I also want to know if someone is a normal metabolizer, because then I can be more confident in prescribing medication, knowing that there's just less risk of non-response, right? So this is not true, and this is confusing, confounding. And again, keep in mind, pharmacogenetic testing tells you which medication is less likely to work, or which can cause side effects, right? For the Stevens-Johnson syndrome. The available apps, still people don't know where to go, which company to maybe buy in, and how much it will cost them, and so on. So this is also all a matter of debate right now, and we're making progress. Medicare, Medicaid is apparently also now financing the first genetic test, so this is amazing. However, it's still unclear who's going to pay for all this. And lastly, sometimes people think that this pharmacogenetic information is taking away as disturbing existing guidelines. No, they're not. They basically tell you if you have 5 medications that you can give, just don't pick the one out of the 5, which is less likely to work, right? So that's how it is particular for treatment in psychiatric conditions. We have alternatives. So we just want to, however, have some guidance here to know which one we should maybe take and which one not. So, and last not least, I just mentioned earlier, if you're interested, what is, I have a Dutch colleague who goes and says, you know, sometimes he goes to physician. He's a chemistry pharmacologist kind of person. He sometimes goes to physicians. He tells them about pharmacogenetics, and they say, you know what, I don't have time for that. You know, like I don't have time to order a test and to read about this, and then to call the patients back at home and tell them so and so. You know, you have a this medication and so on. And then you know, just a pharmacologist, a bit kind of, you know, humoristic person. He says, well, okay, if you don't have the time, my lawyer will find the time with you to discuss it. You know, what I'm saying here is, you know, there have been lawsuits already, and this one is just from yesterday. It's about the manufacturers of clopidogrel, which have not advertised properly back in the late 90s and until 2010. For 12 years, they failed to advertise. You know, they failed basically based on this call here, that metabolizers should be should not take clopidogrel, or maybe getting higher doses, and to specifically warn populations who are much more likely to be CYP2C19 metabolizers, which is the oceanic population. Therefore, this lawsuit was filed in Hawaii, right? So I'm not saying we should do pharmacogenic testing now because of the laws or because of, you know, getting sued, but keep in mind that, you know, you're harming people if you don't do it, and they might get after you at some point if they feel you have not told them and treated them properly. So this is the last slide. Basically, this is a current consensus review guideline that we have just published this last month in January. If you would like to learn more, shoot an email. I'm happy to share a copy. And that's it. Thank you for your attention, and it's been a pleasure to present. Thank you again.
So I do notice that we have a few questions in the chat, but in the interest of time, I'm wondering if we should move forward. So I see Kevin Freeman and Aditya Shah. Will you guys be able to attend the Q&A session?
Sure, I can attend for part of it, yes.
Okay, so maybe let's hold off on the questions until the Q&A, and that way we have time for Victoria to go through.
Okay.
Does that work for everyone? Okay.
Yeah.
Megan, could you, Daniel, could you put your paper that you cited at the very end, could you just put in the PubMed ID into the chat window so we can pop that open, or send us the paper in the chat?
Yeah, good point. Yeah. I think I have a link where you can get it for free. So I will do that. Okay. I will put that in. Victoria, are you able to share your screen now? I just did.
Yes.
Okay, great.
Do you see it?
Sorry.
Yeah. Okay.
Yeah,
okay.
I see it. I see it. Personally, I see
All
it.
right. Thank you. Well, thank you again for having us today at your seminar. It's really an honor to present, and I'll be doing the second half of this presentation where I'll be talking about our experimental research right now, looking at genome-wide predictive modeling. So Dr. Mueller has talked about things already known with particularly pharmacokinetic genes, except here we're going to be looking at more genome-wide perspective. So for my PhD, I have been interested in antidepressant response in late life depression, which is depression in older adults over the age of 50 to 60, and that's an arbitrary cutoff. And so why this is particularly challenging in terms of treatment is there's a hypothesis that individuals who have their depression onset in late life may have some comorbid disorders or vulnerabilities which are overlapping pathways with predisposing individuals to neurodegenerative disorders and cerebrovascular disorders, for example, Alzheimer's disease and strokes. And so from a precision medicine perspective, based on this hypothesis, perhaps we can identify individuals who are liable for these conditions and harness that information in order to predict who may respond to antidepressants or not respond to those antidepressants. And so if an individual is predicted to be a remitter, perhaps that individual may receive standard first-line antidepressant medications. However, if an individual is predicted to be a non-remitter because they are liable for these comorbidities, then perhaps they can receive an additional intervention or an alternative intervention. For example, it has been shown that individuals who have had strokes may better respond to medications which target multiple neurotransmitter systems as opposed to standard SSRIs. So in terms of predictive modeling, that is a tool which we can use to build predictive models. And this is not a new approach by any means, not in psychiatry. However, as opposed to more standard methods using inferential statistics, predictive modeling can help us answer questions about future events. So for example, there are overlapping methods. So if we consider linear regression, it's both method used for inference and for prediction. However, the objective might be different. So for inference, if we're interested in understanding relationships between exposure and outcomes, for prediction, we're interested in finding predictors of future events, but we can use a linear regression nonetheless. And then in terms of assessing how well our model performs, for inference, we may use goodness of fit measures, but for prediction, we can use cross-validation or external testing approaches. So while there are similarities, there are some differences in terms of the modeling framework. So looking at psychiatry and predictive modeling, we did a literature search in 2019 just to assess what is the current state. And we found that predictive modeling in psychiatry goes back to the early 80s. So it's not new by any means, and it has been used to explore various psychiatric phenotypes. And in terms of which modalities have been used to build the predictive models, we saw that predominantly these models were built using clinical measures, so maybe assessments for depressive severity, versus also including more recently other omics and neuroimaging. So neuroimaging is quite widely using predictive modeling. However, if you'll notice, there is not so much genomics applications for predicting psychiatric phenotypes and outcomes. Zooming in even further, so if we look at predictive modeling using pharmacogenetic information in psychiatry, there is even fewer studies. And these list the studies that currently exist. And what you'll notice is that they're exploring various medications. The samples are of different size. They're using different amounts of genetic information. So some use genome-wide information, others use candidate gene SNPs that they've selected. They use different methods, different cross-validation methods, and you'll see that there's quite a bit of heterogeneity in terms of predictive performance. So this is all just to say that there is considerable variation in predictive modeling approaches for pharmacogenetic studies in psychiatry, and there are no clear-cut guidelines about how models should be built. So one of the papers in the previous table is a paper which we published in 2018, which looked at developing predictive models using genome-wide data in individuals with depression who were treated with duloxetine. And since then, we've been further refining our approach to modeling and understanding how different modeling parameters affect model performance and how different genetic parameters can also affect model performance. And to that end, we have been working on an R package, which is a tool to help us build our models, but also hopefully it'll be a tool which will be helpful to other people in terms of creating a more standardized pipeline from start to finish, which integrates best practices, not only in terms of modeling, but also in terms of handling genetic information. So this is the pipeline that we're currently using. I won't go into much detail about it. And so using this pipeline, we are building predictive models now to predict antidepressant response in late life. And so I'll be presenting some of our more recent results on that. So for our discovery sample where we're building our models, we're using a sample called Earl Grey, which contains individuals who are over the age of 60 and are treated with the antidepressant venlafaxine. And they have genome-wide genotype data. And for validating our models, we are using two external cohorts, one called STOP-PD2, which includes younger and older adults with depression who also have psychotic features, and they are treated with an antidepressant and an antipsychotic. And another sample called STAR-D. And these are also younger and older adults who are treated with just an antidepressant, citalopram, and they do not have psychotic features. So the samples that we have access to are still quite heterogeneous, but we're hoping that the models that we build do generalize to other cohorts, particularly if we're looking at antidepressant response versus response to specific antidepressants or specific antidepressant classes. And so using the pipeline, we started with Earl Grey, and we split our data into a 70% training set and a 30% holdout. So we don't touch our holdout, we leave it to the end to assess our model performance. And in terms of the model building within the training set, we start off taking into consideration genetic information. So we're looking at our genetic information, and we're applying pruning for linkage disequilibrium and ensuring that the variants which we are including are sufficiently common to build unbiased models. So we're including, for example, minor allele variants with at least a 5% frequency in the population. And then we also conduct standard processing for clinical data. Once we've processed our data, we then enter the building phase. And so, as I mentioned, we're using genome-wide data. So that means that we're going from approximately 3.8 million variants, and we're trying to whittle that down to a parsimonious amount of variants. And so that requires a two-step filtering process. So we start with a prioritization process where we use univariate prioritization, for example, similar methods used for a genome-wide association study. And then taking the variants which have the highest mean effect, we then further reduce these down using a penalized method, for example, elastic net regression. So hopefully once we've had a smaller number of variants, we'll then select either classifier or a regressor and tune our models internally. And once we've optimized our model after tuning, as we would say, we then test our final single model in our holdout and then our external samples. So as I mentioned previously, STOP-PD2 and STAR-D. So in terms of predicting depressive severity, we build clinical models, so including clinical data only, and integrated models, which include also genetic variants. And so what we found is when we tested in the holdouts, STOP-PD2 and STAR-D, noticeably the model performed the worst in STOP-PD2, only capturing 1% of the observed variants. However, the model did perform significantly in the Earl Grey holdout, and interestingly in STAR-D. Now, when we integrated SNP information, so as I mentioned, we went from 3.8 million SNPs approximately to 25. There are several things to notice. So as you can see, in STOP-PD2, the model still performed poorly. However, the models were still significant in Earl Grey holdout and STAR-D. However, what there is to notice is that in red at the bottom, I'm showing the performance metrics from the clinical models. And what you'll notice is that in both Earl Grey and STAR-D, when we're going from clinical models to the integrated models, the model performance is decreasing. It decreased in Earl Grey, but it decreased even more dramatically in STAR-D. So we lost about 50% of variance explained going from clinical to integrated models. And what this suggests is that the integration of SNP information is introducing noise into these models. So we need to better understand how to capture genetic variation while not introducing noise into our models. So one way that we can do that is by instead of considering single variants, is by considering multiple variants and integrating them into a polygenic risk score. So a polygenic risk score starts from using genome-wide information. And then based on that genome-wide information, which can come from an external cohort, not our cohort, we can then build a polygenic risk score, which is a weighted sum of risk variance in that particular cohort for that particular phenotype. And then we can use this single score to hopefully stratify cases and controls, or remitters and non-remitters. And if we integrate that with clinical information, hopefully we can get a nice stratification. So we recently applied this polygenic scoring approach to predictive models in our recent paper, which was published this Monday. And so we started from a genome-wide approach, a standard approach. So we conducted a genome-wide association study, as I mentioned, in Earl Grey. And we looked at both remission and improvement. So just briefly, in terms of what we found, we did not find any genome-wide significant associations. However, we did see some suggestive associations in potential genes of interest. For example, piezo1 and also ERBB4, which is not highlighted here. But why piezo1 was particularly interesting is this is a mechanosensitive gene, which has been involved in vascular processes, angiogenesis, and response to atherosclerotic plaque in blood vessels, and is associated with apoptosis. So this was a particularly interesting gene in terms of cerebrovascular associations. So we wanted to explore whether we could see a polygenic signal from either neurodegenerative genes or genes that may be involved in pathways related to cerebrovascular disease. So we used a multiple polygenic risk score approach. So we built several polygenic risk scores, which I'll talk about on the next slide. And rather than using single variants within our Piper workflow, we use these polygenic risk scores, which are continuous variables. And so the polygenic risk scores, which we constructed, we used 6 large cohorts of related phenotypes. So we looked at cohorts assessing depression in adults, and we looked at cohorts assessing Alzheimer's disease risk and also risk for cerebrovascular diseases. And then based on those cohorts, we built polygenic risk models, which we applied to Earl Grey. And so what we found is we found 2 particular scores which were associated with remission and improvement, particularly risk for cardioembolic stroke and large vessel stroke. So this was quite an interesting finding. And so we built then our predictive models. So we built a clinical model and an integrated model. Our clinical model included 4 variables, so demographics and clinical variables, including age, sex, duration of current depressive episode, and baseline depressive severity. And then we added in the 11 polygenic risk scores. So what we found is that both models performed significantly within the holdout data set. So as you can see, the clinical model achieved an accuracy of 0.67, so it predicted 67% of individuals correctly. And then you'll notice that when we integrated the 11 polygenic risk scores, we only gained an additional 3% of accuracy. So although we're capturing a large amount of genetic variation from across the genome for various disorders, we're still not capturing enough to sufficiently improve model performance. And the performance here is being driven by clinical information. And just for interest, in terms of what were the most predictive variables, so this is a ranking of the variables and their importance. And someone had asked a question about the importance of sex. And as you can see here, so sex was the top positive predictor for remission status, whereas longer duration episode was a negative predictor for remission status. And then in terms of the polygenic risk scores, the top predictors were, again, risk scores for ischemic stroke and cardioembolic stroke. So the takeaways, I'll start with the challenges. So the challenges are that particularly for antidepressant response in late life, because it's a very specific phenotype, there are a few well-characterized cohorts which may not have sufficiently overlapping measures. So in the first study which I showed, we included 3 cohorts, and we were limited ultimately to the clinical and genetic variables which were present in overlap across those cohorts. We're also suffering issues regarding low signals. So because we're looking at complex phenotypes and there are multiple likely variants contributing to the outcome, it's quite highly polygenic. The signals are not sufficiently strong. And so it's like we're looking for either a causal or a predictive grain of sand in the genome. We also suffer from cursed data. So while highly dimensional or many variables or large data sets can be quite good for predictive modeling, one issue that we're suffering with is cursed data as opposed to big data. So big data may be having a lot of observations or a lot of samples or subjects in your study and having also a large amount of predictors. However, what we have is smaller studies with less individuals and a lot of information, a lot of data, a lot of clinical data, and a lot of genetic information, which we're trying to parse through to build parsimonious models. And lastly, challenges are interpretability. So as I mentioned, since we're interested in prediction, if models are appropriately parsimonious, it does not mean that these are including biologically relevant genetic variants. So it might be difficult to interpret how they're functionally or biologically involved, rather they may be just good predictors. So that is something that we need to consider in terms of moving these models towards, for example, clinical implementation. And another challenge is polygenicity and heterogeneity. So this is a recent paper which was completed by our collaborators at King's College London, where they looked at across 13 large cohorts to conduct a genome-wide association study for remission and improvement in major depressive disorder. So what they found is that antidepressant response in terms of genetics is heritable, but also genetically heterogeneous. So here on the y-axis, they have heritability, and then we have on the x-axis remission and improvement. And in blue, it's showing the SNP heritability as meta-analyzed across whole cohorts, and then heritability which is obtained by combining all the cohorts together. And so we can see that heritability decreases when cohorts are combined, suggesting that there's heterogeneity in terms of genetic contributions across cohorts. So this is one of the things that can make building these generalizable predictive models difficult. Another challenge is that antidepressant response is highly polygenic. So here on the y-axis, they have variance explained, and on the x-axis, they have a p-value threshold, and this is for polygenic risk scoring. So the way we conduct polygenic risk scoring is we obtain a weighted sum across risk variants within subsets of SNPs. And the way we obtain those subsets is by thresholding at p-values. So for example, we'll take all the SNPs that have an association of p equals 0.05 at the genome-wide level, and we'll get the weighted sum score. And that'll be our polygenic risk score, and we can do that at different p-value thresholds. So in this on this side, we'll have the least number of SNPs in the score, and here's a p-value of 1, which means that we're including all of the SNPs. And so what you'll see is this is for remission status. So as we're increasing the number of SNPs, we're increasing our p-value threshold, the polygenic risk scores are becoming significant. And so what this suggests is that not only is antidepressant response highly polygenic, potentially it's even omnigenic. We need to consider the whole genome, the whole architecture, and that will be challenging. But there are also opportunities. So as I mentioned, we have massive amounts of data. While it can be a challenge, it's also great because we're likely to capture additional information which can help us to find predictors which we can include in our models. Also, another opportunity is data integration. So right now we're including clinical data and genetic data, but we can also start integrating other modalities such as neuroimaging, but also other omics information. Especially other omics information can help us potentially boost signals from certain genes, certain pathways, certain processes. Also opportunities associated with predictive modeling is that we're also using approaches which are nonlinear. So we're able to capture nonlinear relationships, and that can be great in terms of boosting predictive power. And lastly, another opportunity is consortia. So now there are many consortia which are integrating cohorts, and so they're leveraging all of the studies that are available and integrating them to not only increase sample size, but also to capture heterogeneity, which can help us potentially make models which are generalizable. That's it. Thank you.
All right, thank you. That was great. I know we have questions in here, so Panjun, do you want to go through the chat questions?
I have an unstable connection right now, so.
Okay. Oh, no worries.
I have read them. Sorry, sorry.
Yeah. Go ahead. I think the first was from Aditya. I'm sorry.
Yeah.
I
I mean, if there is any questions to Victoria first, please go ahead and ask Victoria first. I have just, I've just looked from the other, from my presentation, the questions were posted. There's no order, so I can go ahead if you wish, or wait if someone has a question to Victoria, because it might be more fresh in our minds now.
Hi, my name is Aditya Shah. I actually had a question for both of you, and thank you for your talk, by the way. It was a great, really great discussion and a very interesting topic that you're both pursuing research in. And my question, which I just posted in the chat as well, was about how is this being translated from clinical trials and randomized controlled trials into public policy at the provincial and at the federal level, such as through policies through networks devoted to precision medicine, such as OPMN, or through the through other platforms such as the Ontario Ministry of Health and Long-Term Care, or the Federal Ministry of Health, which is, I think, called Health Canada. And then even closer to home for both of you would be Dr. David Naylor's advisory panel on healthcare innovation, which I think that's the correct title, which focused on precision medicine.
Yeah, maybe I can answer that first. I mean, yeah, thank you for looking this up and for having those detailed questions. Very impressed to have this kind of preparation around your questions. I must say that yes, we have various initiatives, basically, but many of them have different perspectives, so to speak. Some are very academic, like the CPIC consortium I work with, this Clinical Pharmacogenetics and Implementation Consortium. I mean, academic by meaning really looking at the science, at the evidence, and based, doing recommendations based on the science and the data, right? Whereas, you can have a different perspective. You can then say, is it cost effective, right? Or, from a funding agency, do we want to fund a trial and so on? So yes, I mean, it depends where we look at, but, typically I'm more into this kind of translational, translational component, not so much into, the accounting, let's say, something is cost effective or something. I'd rather leave this to the expert. But However, it is of course relevant, and people have questions about that. And I saw one question in the chat was about numbers needed to treat, for example, right? And I think this goes in this direction, maybe, right? So numbers needed to treat is around 7 to 12 or so, something probably around that ballpark, where you would have one case at least after treating 7 or maximum 12 patients, where you would significantly have an impact. And for that client or for that person, you would on average, this is a cost estimate based on different studies, you would on average save at least $5,000 in the first year of treatment, saving money, saving treatment costs, basically lower doctor visits, this is just mostly the direct cost, just really interventionally. The indirect costs that you save by that are not even calculated, because it's hard to kind of find numbers here, I guess. What is the average income of a person and whatnot. So anyway, so it's definitely a good amount of money that can be saved. And if you now know, or if you now assume that genetic testing doesn't have to be expensive, can be done for a couple of $100s, I'm sure, then you will probably get even an overall cost effectiveness value, right? And that's what the insurance companies, and this is what the payers will want to know, right? This is what the governments will want to know, right? Here in Toronto, in Ontario, we have a provincial health system. There's no private medicine basically here. It's the Canadian model, if you wish, and there it's a ministry who decides what's going to be funded or not. And so some of us have conversations with the minister about that regularly, and convincing and arguing and so on and so on. And yeah, eventually at some point I think it will happen, right? But so these are some conversations we have now. With Genome Canada, or I think Ontario, Genome Ontario, I think, which was posted here in this link. Yes, we also got a study funded with them, actually, and we're just about to publish or present the first data, which is called the GAP trial, GAPP, GAP trial. And there we have had basically treatment as usual, where doctors could treat as they wanted and as they are used to, without genetic information. And then we compare this to an arm with pharmacogenetic guided treatment, and see which one is better, how much better, what has been the savings, and so on and so on. This is still data which is in progress to be analyzed. So yes, and it's great to have funding agencies to do fund that, because most funding agencies would rather say, they don't find it innovative, or they want industry companies to fund these trials, because they say those are the ones who are selling the test, so they should be running the trial. Now, if they do run the trial, at the end people say, well, but this trial was industry sponsored, so we don't believe it. So it's a little bit ironic, this kind of situation sometimes, or paradox. And so yeah, there is a lot of things going on. I guess I could go on and list all of them, but I think ultimately it's important to push at all different types of buttons. And again, for example, in terms of reimbursement, which is probably one of the most important things, there is a coalition also in the US called PARC. It's it's a PARC, which is all about convincing governments, but also payers, insurance companies, to fund and sponsor the pharmacogenic testing, and these are great initiatives, so to speak. And I guess we can probably say that we know in 30 years we'll probably all run cars which are not driven by fuel anymore, so to speak, right? And we just don't know how to get there right now, which company we should trust or not. But in 30 years, we'll probably have it. And I guess everyone would agree. And so is genomic medicine in 30 years, probably a normal thing. And right now we're discussing how to get there, and who should get it, and how we do it, and so on. So I guess we just need to find out the best approaches, the most feasible ones, and so on. In the middle of a pandemic, of course, that has also now focused the attention, rightly so, to, of course, get the vaccination now, and a little bit distracted from these conversations that we had before with governments and so on. But I'm sure we will get back to that and resume the conversation sometime soon. I hope that answered the question. Sorry, I was a bit like all over the place now, maybe.
Yeah, you definitely answered the question, and also I thank you for mentioning PARC as well. I think that's something I'd be interested in looking into in the future. Thank you.
I can find a link and put it in the chat. Okay.
I already put it in the chat, but thank you.
Okay, great, amazing. Very, very proactive trainee here. Very impressive.
So I have a very general question. My name is Kevin Freeman. I'm in the GGI department. So just as a thought process, is there a way to capture patients that are non-responders? And I realize some will be due to pharmacogenetics and CYP genes, but what about others? And do you guys have a way to capture them and try to do discovery genetics on them to find out possible reasons to be non-responders to therapy?
In addition to the CYP enzyme, you mean, basically, right?
In addition to the CYP enzyme. So presumably, and I guess you could look at your data, but of the people that are dropping out of sort of dropping the therapy or don't seem to be responding to therapy, how many of them can be explained by the CYP gene, and then who are the remainder? And is within that group, if one assumes that there's also genetic cause for that, do you guys have a process for capturing those patients to be able to look at that?
Well, no, I think we don't have a clear answer at this point, but it's part of the research, obviously, that we're doing, right? I don't think, unfortunately, we have much more than what I mentioned in terms of, drug metabolism genes, and there are some consistent findings. I'm not going to say they don't work or something, but there is, for example, for antidepressants, most antidepressants will target and block the serotonin transporter, and there is a variant there in the promoter that is correlated with gene expression. So again, you can maybe have a person with a more high active serotonin transporter and then one with a less active one. And interestingly, those who have a higher active, or basically who have gene polymorphism in terms of the so-called long allele, they respond better to antidepressants. So, and that has been shown in meta-analysis, but not across all populations to begin with. And then the effect size is relatively small. So to use it clinically, it's probably not very helpful. Like statistical significance doesn't mean clinical relevance, right? And so the few points that you might see improvement in a score like the Hamilton depression score or something are not going to really justify to use that gene. Now, some companies say, okay, it doesn't matter alone, but in combination, maybe with these other genes, it might play a little bit of a role. So we can add it as a kind of, multifactorial, combinatorial approach. And then they build their algorithm, and then they kind of, include even those genes, which we would not normally advocate for. And that is, I think, you can see it both ways. And it is very controversial, basically, because companies would not disclose necessarily those algorithms. So people cannot prove and validate them properly unless they buy the product and do their own assumptions or maybe do their own research. And then the question is it overselling or not, right? So some people are very critical about those kind of multi-gene panels. Ultimately, however, from a scientific point of view, it would probably make sense to not just include one or two genes and then say, this is going to be the test forever and for the future. Obviously, clinical symptoms will matter, for example. And I mentioned earlier, age, gender, ancestry, all these kind of things matter to some extent. They affect response. We've heard we just heard Victoria speaking about the importance of sex, right? So the ideal test of the future will have more than just drug metabolizing enzymes, right? However, we are still in the process, I believe, to build that kind of master algorithm, so to speak, that will incorporate everything to a meaningful extent, such that we can build, really clinically relevant and validated, genetic-based risk assessment tools, right? So we are there. Sorry, we're not there yet. I'm sorry, but we are getting there, I hope, through that type of research that we're conducting. And I think, it's an important conclusion also that, we sometimes we are a bit, we're like everyone in genetics might think sometimes, are we really getting somewhere here? Well, I mean, until we don't try it, of course, we don't know. And this finding that, polygenic or omnigenic will matter in antidepressant response, extremely important for us also to understand, if this research is going somewhere, and if so, how should we address it? And do we need maybe, what else do we need? Maybe genomic research. So there's still a lot to discover. And again, as I mentioned right at the beginning, we still don't know why these antidepressants work. We know that they're targeting the serotonin transporter, but it's just a very simple, very, very simplistic first step that happens. And then something happens down the road in the neurons and in the synapses, and we don't know what it really is. And same with antipsychotics. They all block the dopamine 2 receptor. They all do. They have to, otherwise they don't work, these antipsychotics. But what is happening really after that? Even though, yes, psychosis goes down, like these kind of delusional, hallucinatory symptoms, they improve with antipsychotics, but many things don't. The cognitive impairment that is often associated, the negative symptoms, which means people are not engaging with others and so on, those things remain still untouched by medication. So there's also a lot to learn, maybe to design new drugs or maybe to repurpose existing drugs that we haven't done that far. So yeah, we're just at the beginning. I think we just see the tip of the iceberg still. That's exciting. So, but also, I mean, that's maybe a bit sobering, but it's also very exciting because I think we still have a lot to discover here.
Thank you. That was very informative.
My pleasure. I can look at, if I look at the chat, I think there was one or two things.
One from Athena, maybe. Are you still on, Athena?
Yeah, so sorry, I missed the seminar because I had to go for another class. But whilst we were discussing the paper yesterday in our seminar, I saw that when you sort of focused on just the 2 SNPs that you fell within your interest and you wanted to look at, you only reported on having at least, which is heterozygote individuals, but didn't really mention the individuals that were carrying 2 genes. Did you look at, I wanted to know if you look at individuals that had the 2 genes, if it had any interesting results, or the sample size did not allow for any significant observation from that angle.
Are you saying if we looked at more than 1 gene at a time?
No, allele, individuals that were.
Yeah, no, of course, there will be, sorry, maybe, the acoustic wasn't so good, but I tried try to recap. So, for genes like CYP2D6, which are highly polymorphic, which have probably more than 150 variants in their genes, plus they have duplications, right, that can occur, copy number variants. There is at least a need, I would say, to look at the 10 or so variants, if not more, to get a bit, to get an estimate about the enzymatic activity, right? And by doing those kind of multiple SNPs, and analysis, then you create a haplotype or a diplotype basically, and give them the star alleles, right? So star 4 means maybe that there is a variation here and a loss of a SNP there or something like that, right? And then but you look at more than 1 or 2 SNPs. Is that, I mean, for 2D6, because it's so polymorphic, you have to do that. And if you want to even more inclusive for other populations, other than those that have been mostly studied, you would probably still better include more variants and so on. Maybe at some point include all of the variants that are known. But again, right now it's often just based on maybe of 10-15% of the SNPs. And that's the estimate that however is often sufficient, because you really want to see if the gene is duplicated or if it's truncated, right, at this point of time. And if it's intermediate or normal metabolizer, something in between, it might still matter, of course, but it will matter less. So this is how it's currently conducted. Does that answer the question somewhat?
Yeah, somehow. somewhat.
Sorry, what
Yeah.
did I miss otherwise? We can try again. We can try again if I missed something, but I'm not sure if I, what, you know.
Yeah, or maybe type into the chat too, because sometimes the connection is not so clear.
Sure, yes, of course. You can type it in, of course. Meanwhile, are there chat questions? I don't see any new question, I think. Then let me go back to what I have copied and pasted here.
I see one that just popped up, which asks about data integration.
That's probably for you then, right?
That's David. Go ahead, David, ask your question.
So this is my bias because I'm involved in animal models, but could you include the animal model data, because we kind of have greater signal to noise in animals because we control things better, and maybe that will point you towards particular pathways or networks that are then more interesting in your human data, and sort of integrate that in.
Yeah, thank you. That's a fantastic question and point. So as I mentioned, so we do a two-step filtering prioritization process. So we're prioritizing first by genes or SNPs that are associated. So that's kind of carrying maybe the bias from the univariate models over to the predictive models. But one thing that we're looking at right now is prioritizing by functional significance and also by significance within certain pathways that are known to be involved in processes that are relevant. So that's a great point. If we can use, I think there's probably far more experimental animal data to use the information that's already been found and then prioritize those genes or those variants. I think that would nicely leverage that data and help us kind of avoid biases of overfitting our own data. So I think that's a great point, and hopefully that's something that we can sufficiently integrate into our pipeline soon.
Great, thank you very much.
Thanks.
And Victoria, question earlier, I saw, maybe I picked this up. You mentioned Piper, right? Piper, and I think there might have been a misunderstanding somewhere. A Piper with two R's at the end, Piper double R. .io or something, which was asked, I think, by someone if that's a Piper that you mean, but I don't think that's a Piper that you had in mind, wasn't it?
No, so Piper is not available anywhere yet. We're still trying to compile it sufficiently so that we can publish it. So it's not available yet. It's not on GitHub, and it's not Piper with two R's.
Right, exactly. So because it looked like it could have been similar, I looked up the website. Here it is, piper.io, and that was, if you look at it, it's called a machine learning augmented data acquisition. So it could have really been the one you're talking about, operationalized hybrid data live Piper ML augmented data apps. So maybe.
Yeah, well, Piper is just like a perfect word, they got the pipeline, Piper, R, this is perfect. So I'm not surprised other people have stumbled upon it.
Yeah, right. You might need to copyright it now.
I know.
Yeah. Oh, there are 4 new messages here. Or is it just me that was behind? Who's behind?
It looks like, I think the only, let's see, I think there was one question that Dr. Davenport had asked about patients who have mutations in CYP2D6 or other DMEs and who are poor metabolizers have multiple comorbidities like risk of depression and cancer.
Yeah, so that's a great question because that is ethically important, right? First of all, so if we tell patients, okay, you need a drug, or you need a medication, and we're going to test your CYP2D6 in them for that, the question, of course, is what else do you inform them with, right? Maybe CYP2D6 poor metabolizer could be now terrible news because it might be also associated with some bad form of cancer or something, right? For example, or something else. And luckily, we're not aware of that. So we're not aware of any disorder, any disease so far, so to speak, any medical condition which is linked to those genes that I mentioned earlier that we're typically looking at. We're not aware of that, at least, So at this point of time, we don't feel we have to do genetic counseling for more than what we would do for pharmacogenetics. But it's a great question, again, because it's ethically highly relevant, right? It's like, what are you going to do? And we have, of course, I guess we always kind of forget about, maybe in some talks like this, but since we have a bit of time here, this is great. Actually, I like this forum, by the way, very much. We have had ample time to discuss, and this is how it should be sometimes. I would like to mention that ethical implications are extremely important, right? And again, we sometimes don't talk so much because we have so much data to speak about. We're so excited about the clinical applicability and so on. But we really need to look at the ethics, and also, for example, who should have the right to look at the genetic data, right? I mean, if it's if someone is getting tested, is it going to go to the medical records? Is it going to stay there? Is it going to be available for everyone? Is it going to maybe be also available for insurance companies, and so on, right? Being a poor metabolizer should not discriminate. It just means now you should know about this because you might be better off on another medication. But if understood wrongly, maybe people will get discriminated, by some payers will say, oh, you are the one with lower risk, was higher risk of non-response, right? So I may not insure you, or maybe there was an extra premium or something, right? So we definitely don't want to go there. But, we need to be aware that things can, of course, happen, and we need to have these conversations also. But that's applying not just, of course, to just us, but to everyone here. Keep that in mind, and we have maybe a little bit of privilege, so to speak. First of all, looking at genetics, we don't interfere with genes which are related to disorders. I just said. The second thing is, people typically, when they know about patients, I mean, and I could be a patient tomorrow as well, we would like to know that genetics before we take a medication, so there's a high acceptance there. There is little ethical concerns because, again, it does not necessarily mean something detrimental, right? It's not like testing myself for Alzheimer's or for Huntington, right? Or cystic fibrosis or something like that. I just want to know if I tolerate the medication, right? And that's a very simple thing, I think, much easier and less contentious than doing, disease genetic testing, where I might be still healthy now, but now I know that in 10, 15 years, maybe I will perhaps experience first Alzheimer's symptoms, right? For example, or things like that. So I guess, we have a little bit of, so to speak, some more, some more lee room here, where people don't typically, address ethical concerns as much as it would happen in other conditions, I'm sure. But we need to be aware that they do exist, and particularly when the Non-Discrimination Act, GINA, it should protect, in the US, and we have a similar thing which came years later to Canada, like 8 years later or something. We have a similar act now in Canada too, to non-discriminate people based on the genotypes, and that's, I think, extremely important, of course, to keep in mind. Or two new messages in the chat. I don't think it's a question.
For posting information, that's nice.
Right, thank you.
I just, someone was asking about clinical utility or applications of models and things. And there's a nice paper about the clinical utility and state of polygenic risk scores for clinical implementation. So I just wanted to put that link in the chat.
Yeah, thank you for talking about the polygenic risk scores, because we had Jonathan Pritchard who came and spoke to us to the omnigenic hypothesis, and it's hard to wrap my mind around, how can all of these variants, if so many variants are contributing to disease, how can you use them to dissect different types of genetic architecture? So yeah, these are good resources. Are there any more questions from the graduate students?
I had a question that I'd asked in the chat earlier about malignant hyperthermia in patients with a variant form of RYR, or the ryanodine receptor, and if similar approaches are being used for this as well. But that may be outside the scope of your research.
No, it's fine. I like that idea. I mean, I like that question. Sorry, and I would like the idea of having a genetic test for the neuroleptic syndrome. Now, just to explain everyone, the malignant neuroleptic syndrome is some kind of another hyperallergic, hypersensitive reaction to antipsychotics, formerly called neuroleptics. So the old term is malignant neuroleptic syndrome. It probably happened more frequently with older antipsychotics. That's maybe also why we are not seeing it as much. I have only seen one case in my rich life, so to speak, of being a psychiatrist, and so it is not very common, first of all. So it's going to be hard to do research if something's very rare. And the second thing is, what is it? So it is basically a condition where people start to get really hyperthermic, which means they really get like into the range of high fever as a reaction to an antipsychotic. And that fever can be damaging. That patient I saw had probably cerebral damage from the heat that was produced inside the body. And so that after he recovered, he had ataxia problems and so on, and a little bit of speech dysarthria, like not speaking as clearly. So it's very bad. It's a very bad condition, and it can be seen with other medications. I believe I think it's not just neuroleptics. I think other medications can do this as well. I don't know if there is a specific receptor. Maybe you actually know more than me, because again, it's not that prominent. It's not that common. But you mentioned a gene. Can you tell me more about that gene, maybe, or can you tell?
I'm by no means an expert on it, but the ryanodine receptor, RYR, which allows for, I believe, calcium transmission across a particular membrane in the sarcoplasmic reticulum, which then precipitates some of the symptoms that you were referring to.
Wow, I really missed that, I guess. I would be happy to learn more again, because genetic, if you do 10 genes or 11 genes, as you know, or 10 or 20, that's not what makes the price of a test more expensive, right? I'm saying this because when you do a test, what you pay is a service, the processing, right? The sending the results and so on. That's what costs money now. But if you do 10 SNPs or 100 SNPs, we now know that it doesn't make a big difference. So that gene could be added to the panel if there was a good rationale to do so. So let me look it up. Can you just spell the gene for me, please, one more time? R.
It's RYR, but I'll actually just send you a link in the chat.
Yeah, it could be added to a panel if this holds true. Thank you again. It's great to have an exchange of ideas here. I can tell you one anecdote. When I was presenting a few years ago in Minnesota, Minneapolis, I had this genetic. I was professor of genomics coming to me and saying, "Oh, you're doing pharmacogenetics. Let me talk about my case that I have encountered." It was really fascinating because it happened to his own stepson or something, So he told me, and it was basically that individual that was doing kind of okay, had some condition. They never knew exactly what it was. Like many times, people are just born with genetic conditions. They are maybe a bit, have intellectual disability, learning disorders. You don't know exactly what it is, and so he was. However, at some point, he was deteriorating so much. He was kind of. He was kind of becoming a bit moody. Maybe it was 18, 19, 20 or something. So given him antidepressant, and he deteriorated even further and further and further. So at the end, he was completely regressed, and he was like completely, almost catatonic, right? And so that's when the genetic professor said, "Hey, I want to know what genetic condition that is. Maybe I can do some help here, So he kind of, basically did in his own lab or so. He did an exome sequencing and whatnot, and he found the name of the syndrome, which is called Kleefstra syndrome. Okay, and then he said, "Oh, finally, I know what it is." And then the person who described Kleefstra syndrome is still alive, is still practicing somewhere in Belgium, I believe. So they exchanged each other, but the reality, rare condition, and it's no one knows how to treat it, and there's no treatment. So that was sobering. Now you have a name, but you still can do much about it. So, and then eventually someone said, well, but isn't your son also taking an antidepressant? You know, like have you ever checked about pharmacogenetics? And he said, no, but I have nothing to lose. Maybe I should. So he checked for the pharmacogenetics, and it was a poor metabolizer for 2D6. Okay, being on paroxetine again or something, I believe. You know. So they said, okay, maybe we should remove that medication. They removed the medication, and this person went drastically better. You know, significantly improved. Was basically, you know, removed from all the kind of catatonic symptoms and so on. And what is interesting here is, you know, it's not about, you know, you would never expect this kind of side effect from a CYP2D6 poor metabolizer. Never. You would probably also never seen this in Kleefstra syndrome. But if you combine now two conditions, right? If they interact, you know, if an already maybe, let's say, disturbed, you know, brain functioning, synaptic functioning whatsoever is maybe disturbed because of a genetic syndrome, now you're also poor metabolizer, and you have another basically problem, then being treated with a medication like that one is detrimental. So the lesson learned here is, you know, for genomic interested people to always think also about that someone could have two conditions at the same time, which should be therefore, particularly if you give someone who has a genetic syndrome any kind of medication, particularly now if it's a psychiatric medication, and you know that this person has maybe behavioral or mood or perception problems, you never know this medication is going to work, right? You will never know anyways. It's very off label, so to speak, because these medications were basically only approved for those who have no genetic condition, I would think. And now you do this, but now if you on top of that don't do a genetic pharmacogenetic testing, you bring this, you bring these people probably even more into trouble. So keep in mind that whenever you treat, look also at, think of that, someone has a genetic condition, they might respond very differently and show very different side effects potentially. So keep do the testing as comprehensive as you can, including pharmacogenetics, genes.
It does look like we have a Panjun has typed a question. I think this is for Victoria. Maybe the reason for selecting a particular antidepressant. I think this must be for the study.
Yeah, that's a good question. And at the end, I might lean on Dr. Mueller a bit for the answer. So in terms of duloxetine and venlafaxine, well, first, I think, as I mentioned, a lot of the data that we have is clinical trial data, which comes out of clinical trials and then subsequently to us to look at the predictive modeling of that. And so these are clinical trials which are run independently of us. But in terms of duloxetine, so that study was a pharmaceutical trial where they were comparing the efficacy of duloxetine to placebo. So we've looked at both duloxetine response and placebo response at the genome-wide level. In terms of venlafaxine, so that was in the older adult trial. So although older adults are also treated with first-line antidepressants and SSRIs like fluoxetine and sertraline, there are some hypotheses that other antidepressant medications may potentially improve response or remission rates. And these antidepressants target multiple neurotransmitter systems like venlafaxine, which is a serotonin norepinephrine reuptake inhibitor. So it's targeting both the serotonin and norepinephrine receptor. And in that particular study, this was the first phase where individuals received venlafaxine. And in the second phase, they received an augmentation with an antipsychotic, aripiprazole. So in that particular case, they wanted to see whether this particular medication would improve remission rates, and then if adding the antipsychotic would further increase those rates. And in terms of, I guess, the clinical reasons for choosing duloxetine and venlafaxine, Dr. Mueller.
there isn't really any, I believe, answer that I'm aware of. And I can tell you why duloxetine was used, maybe because it was a clinical trial which was evaluating a new antidepressant called vortioxetine, and they needed some comparison medication. So that's why they used duloxetine, simply speaking, for that, because there was, again, a pharmaceutical trial. The other one, the Earl Grey study, they used venlafaxine. It's just because it is a bit more than just an SSRI. I mean, which is just more than just, you know, just working at the serotonergic system, but it also works on the noradrenergic system, which is supposed to be involved in bit in cognition and in motivation. And so late life depression people, you know, people with certain age and now depression might also suffer a bit more from cognitive problems. So noradrenaline can help them, and a higher noradrenaline, you know, level, and also motivate them more. So I think they just wanted to give a medication which is covering 2 neurotransmitter systems, except that only one. You don't have to do that. Standard treatment is often just with the first one, for example, sertraline. And you know, my recommendations, of course, take one which is a bit broader, like, you know, broader, relying on more than one on one CYP enzyme, right? So you shouldn't go to fluoxetine Prozac necessarily because it's highly 2D6, or paroxetine, which is highly 2D6. Use, you know, Zoloft maybe because it's a bit of 2D6, 2C19, and something else. But a bit safer, you know, in case you don't have the genetic test there, right? Escitalopram maybe also not so good because it's highly CYP2C19 dependent. So particularly now that we learned that in East Asia, oceanic people have higher prevalences of poor metabolizers, so probably also they should probably even less be put on escitalopram before genetic testing. So, but yeah, but that's why I think So you would start simple, but venlafaxine can be given as well as first medication if you have a clinical, you know, if you have, for example, a clinical case where you're seeing maybe noradrenergic stimulation would also help. The reality is, if you go for medications, of course, which target more receptors, might also maybe see a bit more side effects, right? And so I remember that Victoria told me that years ago. She found it somewhere in the internet. She said, "Oh, are these people taking Effexor?" I read on the internet people talk about this as side effects. Right? Remember? I said,
Yeah.
"Say side effects." it might give the wrong notion that this is just a terrible medication, but definitely if you work on two neurotransmitter systems, you might have probably more, you know, there's a higher risk of side effects because you manipulate basically to, but it can be, again, in some people it can help. I hope that's kind of pharmacologically sound. If there's a pharmacologist here, please, and you don't agree, please let me know. But this is basically how decisions are made. They're made basically, you know, you have, and that's exactly the good thing, but it's also the bad thing, right? It's now you have a license as a doctor, and now you have all these medications. You can prescribe them all, and it just depends on you which you like the most, or which you might have had the best experience, or which you might found most convincing to take it. And so there's research that again has shown that the type of the antidepressant that you will get does not so much depend on any personal factors about yourself, but mostly about factors about the doctor. So doctor's age and doctor's sex will determine what medications you're ending up with, because, you know, an older physician might pick up older medications or maybe whatever than a younger physician. And a female doctor, interestingly, will also pick other medications in general than a male doctor. I don't know why, but there is this correlation. So, but that does not mean this is not personalized medicine, right? This is basically nothing. This is nothing. I mean, this is definitely not personalized medicine. This is doctor personalized medicine, you know, and that can't be ideal, right? That does not make much sense, right? So that's why we need this research. Okay. Put simple.
Thank you so much.
Are there any more questions at this point? I almost have to ask Paige. You don't want to ask about 5-HT2A agonists?
Excuse me, what was?
I was trying to prompt one of the graduate students to ask questions about 5-H2A agonists at this point.
5H2A agonist. Is that a question now to us or something, or no?
Well, so I guess so. You know, you guys were talking about late life depression and
Yes.
antidepressants and anti-inflammatories, but so I was going to ask a question about like say LSD, psilocybin, but I assume if you have people with late life depression with cognitive issues, then maybe this is not a good solution.
Because now I see I see where it's going, because a 5H2 agonist is like psilocybin. Is this like a recognized 5H2 agonist? Is that right? I mean, I know that there's a bit of a serotonin system involved there, but I'm not sure if we call it exactly that. But yeah, listen, it's a great question, and because what happens is that sometimes people who are treatment resistant, who don't respond to any other antidepressant medication which is out there, they can nonetheless benefit from other completely different medications, like such as ketamine, or such as psilocybin, such as these, hallucinogens, and LSD is kind of part of the picture, right? What do we mean with response? So first of all, ketamine, the interesting thing is when people get infused with ketamine, sometimes 50% or so show extremely fast responses. Within hours they feel much better, which with an antidepressant would normally take a couple of weeks. So we're stunned by that. Everyone, every neuroscientist, pharmacological researcher, how can this go so fast? What's happening here? And it really seems to be like a super boost, like it really means the synapses are going are going to give everything at this point after a few minutes or so, and that's what maybe makes this effect. Plus other factors, neurotrophins involved, and so on. So that's the fascinating thing about ketamine, which is now also offered as a medication for treatment-resistant depression. And the next one in line might be psilocybin in treatment-resistant cases. And there is some people who have never responded to any medications, and then the moment they take psilocybin, boom, they go and say, finally, I'm out of this coma. I really feel like it's awakening for them. And that's fascinating too. And so we need that research as well. Now, obviously, we need to be careful with these medications. They might impair driving. They might have other problems. Which need to be addressed. So we're not there with psilocybin, but I think we're there with ketamine at this moment of time, that it can be offered as an alternative for treatment-resistant cases, and still has also side effects. Of course, we should not forget that ketamine is not just about without side effects. So and you need to infuse it. So you need to be in a clinic, basically. You need to infuse it many times, maybe, every week or so for 6 weeks, 12 weeks, maybe. And then maybe things go well, but maybe not so much. So it's also not clear right now how often they should then come back to see the doctor to get ketamine infusions. So a lot of things are still in process. And that's, I think, the 5H2 agonist question, correct? Okay. Yeah. So, and at that point, I mean, I'm happy to do ketamine studies, the same I would do venlafaxine here or whatsoever, so as long as we get the samples together, that would be amazing to do, of course. Yeah.
Well, it does look like we've wound through the time, and I appreciate. I know you guys have a very busy schedule. If there's no last questions, I really appreciate you guys taking the time out. I really enjoyed your talks. I learned a lot. And I also appreciate all the resources in the chat that people were nice and added. So
yeah, I mean, that was really, I guess, I think this format like this one should really be more often adopted, like we often have these, 45 minutes plus 15-minute question, right on time, right focus, but I often, when I had longer sessions, like 2 or 3 hours, much better experiences, like I think we really had more time to discuss various things. We could talk about more complex things at the same time, right? We could also, we could also take a lot more question, and maybe also some of them are kind of, I would say, discussions rather than questions, So I really appreciated a lot this kind of format, I must say. And so for me, it was just great experience. And I hope for Victoria, for you as well.
Yeah, it was great. Also perfect practice for thesis defense. Thank you.
That's right. Wonderful. Yeah, so if you are in the field of pharmacogenetics and antidepressants and machine learning and genomics, you will certainly hear more about Victoria, because she's likely to be around for a much longer time now after she will graduate, and will certainly, certainly you might recognize her name, hopefully soon again on related phenotypes. So congratulations, Victoria, very nice talk. I think you're ready now for your defense after this proof here.
All right. I'll tell the defense committee I have your stamp of approval, the whole seminar.
Exactly. All right, then best luck with the weather condition.
Thank
Again,
you.
again, I know it's not a lot of snow, but it always depends again how you're prepared. And Toronto has also not been the greatest being prepared for snow, because we don't have that much here typically, and for some reasons. And so there was once they called the military here because they had 30 centimeters of snow, and the rest of Canada was laughing about Toronto. Because they deal with 6 feet of snow, and we call the military after 1 foot of snow. So that was about 20 years ago or something. And anyway, okay, wishing you all a very nice weekend.
Well, thank you very much, and same to you.
Thanks.
Thank you so much.
Thank you,
Bye,
bye.
everyone.